Hi, and welcome to On Air with Vyaire, podcasts from the front lines, an educational podcast series featuring discussions with frontline medical experts about their experiences ranging from airway management or the dynamics of recognizing, preparing, and managing patients with COVID-19. At Vyaire, we are truly proud to partner with you on the front lines of the COVID-19 global health crisis, and thank you for the work you are doing to help improve outcomes for patients with COVID-19 around the world. The host of Podcasts from the Front Lines is Vyaire Vice President, Medical Director Michael Pedro, MD. This episode is focused on resuming elective procedures during COVID-19 and features our guest medical expert, Dr. Felipe Urdaneta, anesthesiologist, President of the Society of Airway Management, Associate Professor, University of Florida. This podcast is for educational purposes only. The scientific exchange content in the podcasts from the front lines may address the off-label use of Vyaire devices and supplies that are the sole responsibility of the device or supply's owner, and is undertaken with the understanding that the owner assumes all liability for such use.
On today's episode, we'll discuss protocols for restarting elective surgeries. Now, the ACS, ASA, and AORN came out with their joint statement. However, it lacked many details, and it left hospitals open to develop their own policies. Joining us today to discuss some of those finer details is Dr. Felipe Urdaneta. Dr. Urdaneta is a board-certified cardiac anesthesiologist and considered a world-renowned expert in the field of difficult airway management. He is currently president for the Society of Airway Management, associate professor at the University of Florida, and serves as director of out-of-OR anesthesia. He has numerous peer-reviewed publications and lectures all around the world, focusing mainly on difficult airway management and out-of-OR anesthesia. Dr. Urdaneta, it's a pleasure to have you on today.
It's a pleasure to be here. Thank you for having me.
Yeah, we're really excited. So obviously, Florida, in certain parts, haven't been hit incredibly hard yet. And the latest recommendations by the ASA said that they're looking for a 14-day downward trend before elective cases started. Now, in a situation where cases already COVID cases might have been lower, how's your hospital dealing with the situation currently?
Well, actually, interesting question, because it happened yesterday when the governor basically declared that elective surgery should restart. So naturally, for the past 24 hours have been kind of a hectic time because of that. Not that we were not expecting that eventually we were going to be opening. Of course, we all know eventually we were going to open. But when the governor gives you I think it was 96 hours, in other words, we'll be back to work on Monday, not full, but at least with a full schedule and all that, you can imagine that things have been rolling since then. And I've been doing some other stuff this afternoon, so I've been clinical, so therefore I was not available, but I can see, and obviously I'm not reading it, I have about 10 emails regarding that, because I'm sure that there's going to be major confusion regarding what exactly we're going to be doing. This is a fluid situation, and as many things that we have learned with this crisis is learn as we go, and we do our best, but sometimes we don't get it right, and we may do one thing one week and then do the completely 180-degree the next week, because we realized that we were not doing the right thing. So it's definitely a challenging time, and I'm sure is for everyone. So anyways, to answer your question, we have to be fully operational on Monday.
Have you seen the schedule and how many cases?
No, I have not, and I'm not certain exactly what does that mean. Now, I realize that there's been a lot of backlog of cases and all that, but also I presume there will be a lot of reluctance from many patients to come into the hospital if their surgery is not deemed urgent or semi-emergent or something like that, something that can wait. I presume that people will still do the wise thing and wait, and that would be what I would do. For example, I have a problem with the knee, but I'm not even thinking about handling that until kind of the dust settles and we know what's going to happen. My concern is that because of the rush of opening things, then we're perhaps not as robust as we think in terms of testing and things like that, which I'm pretty sure we're going to be discussing. Yes. And therefore, I would rather wait and see what happens.
Yeah, and that brings up a good point. Is your institution utilizing telemedicine for some of these pre-anesthetic assessments, or was it kicked off so fast that some of these patients haven't been able to have pre-anesthesia testing?
Although we should have used telemedicine, we are not. We're using more telephone than telemedicine. Perhaps this has to do with the fact that not all of our patients have access to computers and things like that. So we opted more for telephone than telemedicine. I see the advantage of doing telemedicine specifically for physical examination and all that, even for airway management, but we don't have the infrastructure to do that at the moment. Maybe in other areas of the hospital, they do for primary care. But I mean, the fact of the matter is that this thing caught us in a sense by a surprise. So building up a telemedicine thing for then abandoning it 3 months later, it's not cost effective, right? I mean, you much rather use a low tech thing, which is a phone, and then deal with whatever comes with that voice.
Now, do you know if these patients will have been tested? Is that a requirement?
Well, that is a very sensitive subject, and it's well, we've been requesting for that, and the issue happens to be that we have not had the number of tests that we wanted.
Right.
And we're going by two kind of criteria. Number one is the testing, and number two is the clinical, the presence or absence of fever. So we're doing both. We currently do not have the capacity to be testing everyone, but one of the criteria to open up has been determined to be that the patients need to be tested within 48 hours of elective procedure. Now, if they are positive, of course, they need to have 2 negative tests and be symptom-free for the past 72 hours before they can have surgical procedure. So that's what we're going after. But again, things changed dramatically since yesterday.
Sure. So I'm assuming then, for the meantime, everybody would be COVID positive, would be the assumption?
That's the issue, right? So because of the fact that the uniqueness of this condition is, besides everything else, is the fact that it can be spread on asymptomatic patients, then we're basically treating everyone as if it was COVID positive. And so we're doing full PPE, gown, eye protection, special N95 mask, and all that, and considering most of our procedures aerosol generating procedures. So yes, it's been a little bit of a hassle. Now, fortunately, that's the disadvantage. The advantage is the fact that since we're not doing elective procedures until today, then we do have a little bit more time and not so much pressure as we normally do to be rushed about this, because we do have to wait 20 minutes before we're able to do anything after either the beginning or the end of the case because of the aerosolized particles in the room.
Thank you for joining us today. To suggest a topic for future podcasts from the front lines or to stay informed, please visit us at Vyaire.com.